Good afternoon. This is Dr. McDaniel. Today is Monday, June 10th, and I'm back at the office today. Mondays we always start earlier. We start at 9 on Mondays, so I don't usually have time to do the presentation in the morning. So it's the lunch hour right now. So good afternoon. It's a rainy, cloudy, overcast day in New York City today, but we had a good weekend, so can't complain too much. Although it is June, should be nicer weather in June. What can you do? So yesterday I spoke on postmenopausal bleeding, or bleeding that occurs after someone has gone through menopause, and today I'm going to continue speaking on postmenopausal bleeding. So I'll do what I think is going to be a brief recap from yesterday's presentation, and then I'll go over, I'll add to it today on diagnosis and treatment, how to address it. So postmenopausal bleeding, or bleeding after menopause, is any bleeding that occurs, whether it be brown, smudgy, which we call staining, or pink, red drops, which we call spotting, or full-on menstrual period. Blood is blood is blood, whether it's brown, red, pink, purple, burgundy, doesn't matter, or black, it's still blood. So it's any kind of bleeding or any amount of bleeding that has occurred once someone has already been diagnosed as menopausal. And the definition of menopause is no longer getting a menstrual cycle, and it's been more than 12 months in the face of blood work that confirms menopausal state and or symptoms that are consistent with menopause. The most common of those symptoms being hot flushes and night sweats. So if someone's gone through menopause, they are not supposed to have any amount of bleeding, vaginal bleeding at all. So the evaluation is to confirm that it really is due to uterine bleeding. So we will always, or should always, do an exam. The exam is to confirm that the bleeding isn't potentially from hemorrhoids or anal fissures or vulvar vaginal fissures. So fissures are cracks or cuts in the skin that can easily bleed. Could be a polyp, so a skin polyp or a fibroepithelial polyp, those are known as skin tags. Those can sometimes ulcerate or outgrow the encapsulated skin layer, so they will start to bleed. To confirm that it's not due to vaginal or vulvar fissures, which will often occur if someone has had chronic skin issues, so eczema or contact dermatitis. Then we'll look to see if it's potentially from tears or abrasions of the vaginal vault or the opening of the vagina, which we call the introitus. So a tear or an abrasion could be due to sexual activity. The postmenopausal tissues are usually much more fragile than the vaginal vulvar tissues when someone's younger. So menopause is an estrogen deficient or depleted estrogen state, and estrogen is the hormone that maintains the normal vulvar vaginal tissue elasticity, suppleness, and moisture. Once someone's gone through menopause, those the changes that occur will leave that woman with a thin, fragile, and dry and very delicate vaginal tissues. We call that vaginal atrophy. So those tissues with the sexual activity can easily tear and rip. So we'll look at the vaginal opening or the introitus to see if there's any evidence of tears or rips or rug burns, which are abrasions, and then we'll also look in the vaginal vault for the same. As I mentioned yesterday, some women will ulcerate due to the vaginal atrophy, so the tissue gets so dry and thinned out that it starts to just form a hole or a firm depressed area in the vaginal tissue. We'll also look at the cervix to see if it's inflamed or fragile or bleeding, or if there's a polyp that could be the source of the blood in the cervix. And then if everything on the vaginal exam is normal, no obvious source as to why this lady's having bleeding, then we'll always draw bloods. And the bloods are to confirm her menopausal state, and also to confirm, even though it does not occur often, it can potentially occur, that there isn't an outside of the normal route, normal mechanism, an outside or an exogenous source of estrogen, because estrogen stimulation of the uterus will cause bleeding. So rarely, but it can happen, someone can have a cyst on the ovaries, a teratoma that produces estrogen, and that estrogen can stimulate tissue buildup and potentially bleeding in the uterus. Additionally, fat is an external or an exogenous source of estrogen. So if someone is really obese, that fat layer can potentially stimulate the uterus to build up blood, and because it's not a normal stimulation pattern, it's an unstable lining of blood that builds up, so it can potentially bleed randomly, wantonly, without rhyme or reason. So we'll do the bloods, and the blood is the usual hormone panel that I've mentioned previously. So those bloods are pituitary, brain, which is prolactin, thyroid levels, thyroid function tests from the thyroid, and those are just done to confirm that there isn't a medical reason as to why she's not bleeding, and that she's still fertile. So we draw those to confirm that there isn't another reason that has stopped her cycles for over 12 months. And then the ovarian hormones, brain and ovarian hormones, are luteinizing hormone, follicle stimulating hormone, and estradiol. The first two, the LH and the FSH, should be elevated, and the estrogen or the estradiol should be very, very low. And most of the labs will report it as less than 32 picograms. So that's the hormone panel. And then we will always check to confirm that there isn't an infection. Now, it's very rare, I shouldn't say rare, it's not common for someone who's gone through menopause to get chlamydia or gonorrhea. I have seen it, but that's not common in 27 years. I have not seen it often. I think I've seen it twice. They can potentially get chlamydia or gonorrhea in the bladder. It would be very difficult to get it cervical vaginally because the tissues are just not conducive to hold or to maintain a chlamydia gonorrheal infection, but the bladder tissues will sometimes be able to support those two infections. So we get chlamydia gonorrhea just to confirm that the bleeding's not from an infectious inflammatory change. And then we'll also send the urine to confirm the same for regular bacterial infection. Now, once we know there's nothing physical that's the source of the abnormal bleeding, there isn't an infection that's the source, there isn't a medical condition, then we look inside the uterus macroscopically to see if we can see anything with the naked eyes. That macroscopic evaluation is an ultrasound or a sonogram. The ultrasound is to confirm that there is not a mass, a cyst, an exogenous source of hormonal stimulation that could cause the bleeding, and then it's to look inside the uterus to confirm that the lining that normally builds up to form a menstrual cycle, that it's still thin and non-stimulated, and that lining should be 3 millimeters or less. If someone's on hormone replacement, we'll give them an extra 2 millimeters, so 5. But predominantly, most women nowadays are not on hormone replacement. So that lining, we call that the endometrial lining or the endometrial echo on the sonogram or ultrasound. It should be 3 millimeters or less. Now, if that lining is thicker than 3 millimeters, or if there's a mass or a growth or any kind of tissue aberration or change that's seen on the ultrasound, then further evaluation is warranted. And I'll go into that tomorrow. So this is Dr. McDaniel at GYN Corner. Thank you for watching. This has been the part 2 presentation on postmenopausal bleeding or bleeding after menopause. Please check out the YouTube channels. That's also GYN Corner, where every day's presentation, and I do daily presentations, where the daily presentation is listed on the date and the topic on my GYN Corner on YouTube. I'm looking to try and also get something on Instagram, but I'm thinking maybe for the end of the summer I'll try to figure out Instagram, because I don't know anything about Instagram, but we'll see if I can get something going on Instagram. But for now, it's Facebook page and YouTube, and I'm here in person, Midtown Manhattan, around the corner from Penn Station and Macy's in New York City. We're here Monday through Friday, GYN care, and first trimester for pregnancy. Thank you for watching again. Have a great rest of your Monday, and we'll be back on Tuesday. Bye.